So today I'm going to do a bit of a different talk to usual. I'm kind of, rather than focusing on a specific piece of research, I'm just going to give an overview of the research I've done and kind of reflect on my approach and I guess the challenges of obtaining funding, but also conducting research in with underrepresented groups. And yeah, hopefully these insights will be helpful. So a sort of brief outline, I'll firstly talk about kind of the bias that currently exists in research, and then I have sort of two case studies of strands of research I've been involved in, ARFID and mental health and rare genetic conditions, and then sort of finally some reflections. So when putting this talk together, it reminded me of a lecture from my undergraduate psychology course. And there's a lecture on decision making, focusing on and introduce the idea of heuristics. As humans, we make mental shortcuts or rules of thumb that allows us to make decisions quickly and and to problem solve. In the moment, we're not calculating probabilities or doing complex mathematical calculations. We're making kind of quick judgments using rules of thumb. And one example of this is the availability heuristic, a shortcut where we judge the likelihood of frequency of an event based on how easily examples come to mind. And so to give an example of this, if I was to ask people, which has the greater population, the city of New York or the city of Cardiff, most people would say New York. It's well known that it's a large city, and it's featured a lot in popular media. If I was to ask you which is bigger, the population of New York or Chongqing, that would be a harder question. We're biased to our knowledge around European and American cities often, and we may get this question wrong. So Chongqing is actually larger than New York, but some people may not have heard of it. And this is just kind of a very simple example of how availability of current knowledge and awareness sort of shapes our decision making and judgments. And this can lead to kind of irrational thinking. So, for instance, fear of flying can be linked to, the overexposure of plane crashes in the news and the media. Similarly, ignoring climate change because that's a gradual change. It's not always at the front of our attention, and we may underestimate it. Many of us buy lottery tickets, even though the odds are very low, because we see videos and images of people winning the jackpot. And this also affects health and research. I thought this study was really interesting, investigating whether doctors and patients can estimate cardiovascular risk. And what was interesting, the groups where they underestimated risk were females, individuals from a younger age, and non-smokers. And the article kind of speculates whether this is due to kind of stereotypes and the sort of individuals included in kind of news items in the media when discussing about cardiovascular risk. And this has an impact on the research that gets funded and the areas that receive research attention. Perceived prevalence often does influence areas where there's research capacity. And this is further intersected by stigma. So if a condition is stigmatized, it may we may be likely to conclude that it's not as prevalent or not as important as issue. And there can be a lot of complex interacting factors. For instance, if there isn't currently service provision for a certain health condition, there's a lack of clinical visibility. This could lack this may then seem that there's a lack of prevalence of a condition in a population, even if there is a great clinical need. And similarly, just by labeling an issue as rare, that could change perceptions within clinical services and research that this is perhaps an area that doesn't need much focus in the future. And this can lead to sort of vicious cycles. If there's a lack of clinical visibility, there's a lack of clinical innovation, and there's a lack of impetus for research capacity, we don't find out more about this condition, and it's still perceived as something that may not be that prevalent or as important. So the first case study from my research, I'm going to talk about the eating disorder ARFID, which is the focus of my current Wellcome Trust Fellowship. Within the UK, a report from the All-Party Parliamentary Group on Eating Disorders found that on average we spend £1.13 per person with an eating disorder per year. That's less than the price of a cup of coffee. Yet eating disorders associated with a high mortality, and they account for around 9% of individuals in the UK with a mental health condition. Yet eating disorders only accounted for 1% of mental health research funding. And this is having an impact on clinical care, lack of research, lack of clinical advancement. And there's also a problem in eating disorders research that because of the lack of research capacity, most of the focus has been historically focused within London. And within eating disorder research, most focus is on anorexia nervosa, and there's been very little attention on ARFID. ARFID stands for Avoidant Restrictive Food Intake Disorder, and this is where an individual restricts the amount of food they consume or the range of foods. And it's driven by behavioural drivers such as lack of interest or lack of appetite, sensory-based aversion, so this could be to certain sensory properties of food like texture, smell, or how the food looks, and also fear of aversive consequences. So this could be following a choking incident or an allergic reaction. Sometimes ARFID gets sort of mislabeled as picky eating or simply food fussiness, but it leads to severe consequences, including malnutrition, physical and mental health complications, dependency on feeding tubes. It was introduced to the DSM-5 in 2013 and had previously different clinical specialities used different labels, and the introduction of the ARFID diagnosis unified these and has focused clinical and research attention. In terms of the sort of DSM-5 criteria for this condition, it's different from anorexia nervosa or bulimia nervosa in that there aren't shape or weight concerns or body dysmorphia. Rather, the restriction is driven by the things I mentioned before: sensory, lack of appetite, and fear. And to meet the clinical thresholds, this has to lead to either weight loss, nutritional deficiency, reliance on supplements, and or impairing psychosocial functioning. And it very much sits within the DSM-5 eating disorder category within the sort of 6 main eating disorders. So only a couple of months ago, there's an article explaining someone's experience with ARFID, and the article describes it as a rare eating disorder. Yet, if we look at some of the published prevalence data, around 1/3 to 2/3 of individuals referred to feeding clinics meet ARFID criteria, and within the general population, estimates range between 1% to 6%, and a recent meta-analysis showed 4.5%. And then, research has shown there's a range of psychiatric comorbidities and co-occurring physical health conditions. And this prevalence of 4.5%, this is, similar to ADHD and autism, yet there's much less clinical awareness and research attention comparatively. And we wouldn't describe autism and ADHD as rare conditions. And so this is just an example where perception can, lack of awareness and lack of current clinical services for ARFID lead to something being seen as rare, even though the research is telling us otherwise. And work I've been doing as part of my fellowship with the Norwegian cohort, we showed in a collaborative paper that 6% of children in this cohort of over 30,000 families met criteria for ARFID. 2% had persistent ARFID across childhood. This paper also looked into the genetics of ARFID, and then that showed it was very much a condition that had kind of both brain and sort of body components in its genetic biology. And then also work I've been doing with the ALSPAC study. So this is children who were born in the 90s in the Bristol and Avon area who've been followed up, and they're now in their 30s. So out of 4,000 adults, 6% said they've been told they might have ARFID, and 1%, just under 1%, said a clinician said they might have ARFID. Again, this isn't the sort of statistics you'd see for a rare condition. We're now starting to look at the prevalence of ARFID within the Born in Bradford cohort, and teenagers across Bradford schools are completing an ARFID screening questionnaire. Sometimes, ARFID is stigmatized, or sometimes it's dismissed as fussy eating, or it's just a phase of picky eating. But it's a serious medical condition, and this is perhaps what's led to a lack of previous sort of clinical and research awareness. Here is a picture of a teenager who went on this morning, and his ARFID led to him developing nutritional optic neuropathy. His diet of just crisps and chocolate was leading him to go blind. So ARFID can have real serious consequences if individuals don't receive support. And there's also been the sad case of Alfie Nichols, who, although he had a diagnosis of autism, his ARFID was undiagnosed. This sadly led to malnutrition, and he passed away. This has since, the coroner's verdict has since led to a re-evaluation of services, and services are starting to develop for ARFID. But this just highlights that sometimes people think fussy eating is, part of the autism diagnosis and doesn't warrant further diagnoses and clinical attention. And this was a really clear case of the need for the diagnosis of ARFID. So it can sometimes be a challenge to kind of challenge these perceptions, if people say, I've not heard of that condition, or, that must be very rare. And I guess my approach is just to present, the evidence base, the statistics from the research literature showing the emerging uh, prevalence figures. But also importantly, is to highlight the lived experience of children and families affected by this condition. And here's a photo of me with ARFID awareness in Parliament Square. And also just engaging with clinicians and policymakers. And I think what's starting this project on ARFID research, it's really changed my perception on how I kind of approach research, realizing that it's also a platform for advocacy as well as, developing evidence. And so when I was developing the funding application for this work, I worked closely with BEAT, and they shared quotes from families that they'd done a survey of, and this just really highlighted to the funding panel the need for ARFID research, but also how many families were struggling. There was a need to develop more information resources on ARFID. And similarly, working closely with BEAT gave sort of important kind of clinical and policy insights. So they were sharing how there's been a large increase in phone calls to their helpline on ARFID, and it was BEAT who also made the really important point that currently there were no clinical guidelines from the body NICE for ARFID, and this was because there was a lack of research. And to me, this just really emphasized the need to apply for funding for research into ARFID. And the benefit of working with a range of stakeholders in developing the research proposal meant that once the work was funded, I already had those connections and partnerships, and this has led to a really interesting and rich range of clinical and policy impact. Important consideration of sort of approaching this research project at ARFID is inclusive research design. One of the reasons why there's not been much ARFID research is because not much data exists. Within the NHS, not many individuals have received a diagnosis. So how do we go about understanding this condition more? Services are still very much in development. And the approach I took was to use population cohorts. Some of these cohorts involve registry information, so perhaps capturing individuals who perhaps wouldn't take part in a study run through a hospital or a clinic, or they may involve brief questionnaires, so it's not that burdensome on families. So for two of the cohorts, the Norwegian cohort and then the Bristol cohort, in childhood, information, an ARFID questionnaire hadn't been included, so we created an ARFID algorithm based on existing questionnaire data and using clinical record data to derive ARFID scores. And then in the Bourne and Bradford cohort, a new questionnaire was included. And what's I think really exciting about the Bourne and Bradford cohort is that 50% of the cohort are from a British Asian background, and also the cohort is overrepresented for individuals from a low socioeconomic background. And these are both groups that have been historically excluded from eating disorder research. And so the hope is by using this sort of population cohort design, we're perhaps able to capture some individuals who may who historically have not been included in research. On to my sort of second case study, I'll discuss the research I've been doing in mental health in rare genetic conditions. And here you may be thinking, well, rare is in the title, rare genetic conditions are inherently rare. But the point I want to make is collectively, rare conditions affect 1 in 17 people. This is a substantial proportion of, of the population. And, by focusing attention on individual conditions, this is potentially missing the bigger problem and the overall health needs of individuals with rare conditions. My research particularly focuses on rare conditions caused by genetic changes known as copy number variants. So where there's section of a chromosome that are deleted or duplicated, and I'll refer to these as CMVs. Large-scale studies have shown that certain CMVs occur more within individuals with neurodevelopmental conditions versus neurotypical individuals. And again, although individual CMVs may be rare in the population, within intellectual disability, they may represent 15 to 20% of individuals. Within autism, 7 to 10%, and within schizophrenia, 2 to 8%. And the studies that have kind of investigated this, they conclude these percentages are high enough to warrant referral for genetic testing within these groups. And historically, we've tended to think as genetic testing only kind of referral, more so for physical health issues. And the diagnosis of rare genetic conditions as genetic technologies improve and become more widespread is only increasing. Over 4,000 new diagnoses are made each year. So, the issue of provision for rare genetic conditions is only growing. There's also a lot of enthusiasm and discussion and pilot studies for newborn genetic screening. But if anything, although our genetic technology is advancing, we don't necessarily always have understanding or insight into what the impact of certain genetic variants are on child development. So this can lead to a situation where we're giving genetic diagnoses but not really knowing the prognosis of those conditions. And even within rare genetic conditions, there can be differences in our understanding that aren't related to prevalence. So for instance, my research has focused on 1q21.1 deletion and duplication conditions, but because the genetic test only came about in the last couple of decades, and there's been relatively less research publications compared to Fragile X syndrome, which, although it's a similar prevalence, there's been historically was discovered earlier and we know more about. And so the goal of the Imagine ID cohort was to start a move away from research that focuses on individual conditions and start to look at the developmental and mental health needs across a range of genetic variants. And so to take part in this study, children had to be aged 4 to 19, and they had to have a rare genetic variant that was linked to intellectual disability or neurodevelopmental delay. And this also addresses another bias in neurodevelopmental research, in that individuals who have neurodevelopmental conditions and co-occurring intellectual disability have often been underrepresented. So I think the majority, 94% of research into neurodevelopmental conditions did not include individuals with intellectual disability, yet yet half of individuals with neurodevelopmental conditions have co-occurring ID. So the Imagine ID study is also, trying to address this sort of lack of focus of understanding in co-occurrence with ID. So trying to understand the needs of children who have developmental delays. Part of the reason there hasn't been much research is that studies haven't always been inclusive, or study design and measures haven't always been accessible. So we took two approaches in this study. All participants did online questionnaires. So this meant caregivers could do this from their own homes. They wouldn't necessarily have to go into a hospital or clinic, which can be a huge barrier, particularly if a child has complex needs. And then the other approach was in 500 families, and we did visits in their homes. So rather than asking them to come to a research centre or to a hospital or a clinic, it means we could be flexible around the family's schedule. And also in the researchers who did the home visits were trained to ensure that the assessments were flexible. We gave lots of breaks, and to make sure that the assessments followed the sort of pace and developmental level of the child. And within Imagine ID, we really took the approach as caregivers and children as professionals and experts in their own experience. Often previous research into rare genetic conditions has focused on asking, clinicians to fill out, to tick off, lists of conditions that an individual may have. In Imagine ID, we're asking parents to complete online questionnaires, and then in the home visits we did the interviews directly with the young people and with their caregivers. And in terms of recruitment, although it was a huge undertaking, we had many individuals who wanted to take part because there's just a great hunger to share data amongst the rare genetic condition community and to contribute to improved care. Something that we thought a lot about, particularly because there hadn't been much research previously on mental health and rare genetic conditions, is that this group can often find it difficult to access services. And so we really wanted to make sure that we gave something back as researchers for families giving up their time. So as part of the study, individuals received a report about their child's development, and we did a 5-year follow-up of the impact of those reports. 99% of caregivers reported a positive psychological impact. It changed the understanding of their child. And first, it just showed that there's a benefit in taking part in research in of itself to the participant. There were a range of other impacts. Around a third, it led to improvement in their young person's quality of care. And so now I'm going to present work led by Dr. Jan Wollstonecroft that summarise some of the online findings. And so through this online approach, we're able to gather detailed information on over 2,500 children with a rare genetic condition. And we use the Strengths and Difficulties questionnaire that looked at behavioural and mental health difficulties in children. So at the bottom is the UK norms, where 80% of children fall within the average range. For children with rare genetic conditions, 83% fall within the above average, and 53% fall in the very high category for behavioural and mental health problems. Just emphasizing, the burden of mental health problems in this group, and that children with rare genetic conditions as a whole represent a vulnerable group for mental health problems. And when we looked at individual diagnoses, autism, ADHD, and oppositional defiance disorder were elevated in children with rare conditions. And this was further validated by the in-home visits, where nearly 80% of children with a rare genetic condition met criteria for a psychiatric disorder. We also looked beyond diagnosis, and based on all the in-depth interviews with children and caregivers, we found these conditions had a range of impacts across IQ, cognitive abilities, psychiatric symptoms, sleep, psychotic experiences, neurodevelopment, motor development, and then also behaviour and mental health as rated both by the teacher and by the parent. Again, just adding to the overall message that, it's not just, there's not just, one or two specific genetic conditions that lead to mental health problems. This as a group, this population have great clinical need for support. And so these findings led to a range of invited talks to hospitals across Europe and the US, and the work was cited in a range of policy reports and presented to Welsh Government and the Welsh Paediatric Society. And as well as giving insights into the needs of this group, previously there'd been a lack of research. It also established these rare genetic conditions as risk factors for mental health, which has now led to kind of future research using these genetic conditions as models for neurobiological research into mental health. So we've been there's the Sleep Detectives project, where we're looking at the relationship between genetics, sleep, and psychosis outcomes. And then also at Cardiff University, we have the Connectome scanner, where we can look at brain microstructure in these conditions. So moving more on to kind of my sort of take-home messages and reflections. As humans, we often take shortcuts in estimating frequency and importance, and this does have an impact in the clinical and research spheres. The research literature and current research capacity in universities is likely biased and not necessarily always aligned to clinical need or clinical prevalence. And this can lead to a vicious cycle of underserved groups. If there's a lack of clinical visibility, there can be then a lack of research. Working with conditions and working with groups where historically there's been a lack of research can be challenging, and this is where inclusive research designs can help. And I think the biggest thing that I've learned over the years is moving away from this idea of research subjects to developing meaningful community partnerships in both developing the research and disseminating research and development of impact. I guess some tips when developing a funding or grant application, and it can be challenging because when I was developing a welcome funding application for ARFID, my biggest concern was most of the panel won't have heard of ARFID before, and they'll probably think it's a rare condition, or they might underestimate it and think it's it's just fussy eating. And so I really spent time introducing what ARFID was, and made sure not to assume that the reviewers or panel would have any knowledge of the condition. And I think in doing this, helped me articulate the clinical need and link by discussions with charities and clinicians also further, and individuals with lived experience further emphasize the clinical need, and that was very helpful in the writing process. I think the things that helped me most in writing was actually getting away from my desk and, just getting out there and speaking to the communities this research impacts. And asking for help. Off charities such as Beat had already done significant engagement with the eating disorder community, and had a range of quotes and key discussion points that I could bring into the grant proposal. And finally, just to be discerning with advice. People say, "Oh, that's a rare condition," or people won't have heard of that. It's going to be a real struggle to get funding. But if everyone took that attitude, we would never make advancement. And often the areas which are underrepresented are often the groups that are in the most clinical need and the most need for research. But it's not just in the individual researchers. I think it's important to reflect on this issue. It's also important for funders to reflect. And earlier on in my career, I had a Medical Research Foundation fellowship, and they did a call where it was just focused on eating disorder research. And I think this ring-fence funding approach is really important for increasing research capacity in areas where there's been a lack of research. I've also benefited from rose trees who've taken a personal interest in ARFID research. It's often meant sometimes reframing my research ideas and thinking out of the box. And ultimately the areas of health where the most advancement is happening, it's due to large-scale centre or network funding. And I think that's it's important for funders to recognise the transformational change things like centre funding can lead to. And my, I guess, sort of final thought is over the years I've started to see research as advocacy. When I started my PhD, I was very focused on the data and getting the publications, but as researchers, there's a real opportunity to shine light on issues that have been previously neglected. But also it means so much for individuals living with certain conditions to know, just to simply know that research is being done in that area. So I'd ask everyone to sort of reflect on their own work, and in research, clinical work and academia, there's so many demanding priorities, but just that your research matters so much to the individuals who are affected by it, and not to forget that. So on that note, I'd like to say thank you for listening, but I'd also like to thank all the funders and collaborators and team members who've supported me in this work. And yeah, thank you for listening, and looking forward to your questions.